Hello and welcome everyone. Today we'll be doing the journal review of paper of Landiolol for heart rate control in septic shock patients. Septic shock is causes inflammation leading to hypovolemia, decreased cardiac output. The sympathetic activation triggers tachycardia, vasoconstriction, and increased inotropy to maintain the perfusion. Standard treatment that we use is usually fluid resuscitation and vasopressors. But some patients they have persistent tachycardia despite treatment. Tachycardia more than 95 is linked to higher mortality, while a control rate of around 80 to 94 is considered optimal. So, what is the role of blocker over here? Beta 1 selective blockers, that is esmolol and landiolol, are studied for tachycardia control in septic patients. The benefits that I've seen is improved stroke volume, reduced lactate, lowered NORAD requirements, better organ function, and survival rates. Compared to ivabradine and amiodarone, beta blocker has pleiotropic benefits. It attenuates the sympathetic overstimulation, improves the microcirculation, reduces inflammation and coagulopathy. Non-selective ones are less suitable for acute sepsis due to the longer duration of action. Regarding landiolol versus esmolol, landiolol advantage over esmolol is that it has a shorter half-life, 4 minutes, higher beta 1 selectivity, less impact on cardiac contractility, and lower impact on blood pressure, so lower risk of a hypotension. Clinical trials that have been done are two. The JLand 3S study, that is from Japan, it showed significantly reduced heart rate, that is 60 to 94 in 24 hours, lower 28-day mortality, though not statistically significant because it was a small population. The Stress L trial, the study stopped early due to lack of clear benefit and potential harm, and it did not demonstrate improvement in organ function. So the methods of this particular trial were that first the ethical clearance was taken, and it was conducted based on the Helsinki Declaration. Independent ethical committees they approved the trial in each of the centers. Written consent were taken, and independent data monitoring committee reviewed the trial data regularly. The design was multicentric, randomized, open-label, controlled phase 4 trial. It was conducted across 20 sites in 7 European countries. The ICU patients with septic shock and persistent tachycardia, that is heart rate more than 95 beats per minute, were included. The primary objective was to assess whether landiolol reduced heart rate and maintained it without increasing the vasopressor requirement. Secondary objective was to evaluate the efficacy and safety of the drug compared to standard treatment. Regarding the patient selection, adults with septic shock, sepsis 3 criteria, persistent tachycardia despite 12 to 36 hours of hemodynamic optimization as per SSC guidelines. And the exclusion here were patients with compensatory tachycardia, which was determined by the investigator. Randomization was 1:1, stratified by the presence of AF. Blocked stratified randomization ensured balanced treatment distribution. Open label design due to lack of specific treatment in the control group. Treatment protocol, Landiolol group. The received standard SSC guided treatment plus continuous Landiolol infusion. The dose titration was started at 1 microgram per kg per minute, increased to 40 microgram per kg per minute in a 20 minutes interval. Target was to achieve a heart rate of 80 to 94. Treatment continuation was done until the vasopressor discontinuation was done or until death. Serious adverse effects were noted during the study period from ICU discharge or day 28, whichever was earlier. Treatment protocol, the control group, again they received no specific heart rate control measures. The rest was essentially similar. Treatment endpoints was vasopressor discontinuation and death. ICU discharge or day 28, beta blocker initiation led to study discontinuation. Study procedures, hemodynamic monitoring, recording were done every hourly, then every 12 hourly until treatment ended. Vasopressin and inotrope dosage was monitored every dose change. Additional trial procedures described in the supplementary materials. Regarding the study endpoints, the primary endpoint was the multi-component outcome, that is heart rate response, the heart rate maintenance, and the vasopressor increase. Failure criteria was met when the heart rate was less than 80, was not considered failure if it was clinically insignificant. Patients who died or received beta blockers within 28 hours were counted as not reaching primary endpoint. Secondary endpoint was vasopressor requirement, that is dose duration over the study period, mortality 28 days, the length of stay, the organ failure, and the safety outcomes were assessed by bradycardia and other serious and adverse effects. Regarding the statistical analysis, comparison was done between the two groups based on absolute and relative frequencies using the Cochrane-Mantel-Hansel method for stratification by AF and study site. Superiority test, Landiolol considered superior if the lower limit was 95% confidence interval, and patients who died or received beta blocker within 24 hours without reaching primary endpoint were classified as treatment failures. Regarding the safety, full description has been given of the statistical plan. Subgroup analysis is mostly post-hoc and exploratory. Regarding the results, 2079 ICU patients were assessed for eligibility, 1879 excluded, 200 randomized, 99 assigned to Landiolol group, 28 received, 1 was screened failure, 101 assigned to the standard treatment, 98 received, 2 were administered beta blockers, that is they required beta blockers, 1 there was withdrawal of consent. So out of the 99, 43 died in the Landiolol group, 98 of patients, 49 discontinued the study, out of which 32 died, 15 had to be administered beta blocker, 1 was withdrawn consent, and 1 discharged from the site with vasopressor. So regarding the baseline characteristics between the two groups, they are comparable. There is no much difference between the two groups. Regarding the primary efficacy, the primary response was clearly better with the Landiolol group, where we did achieve the targets which we are trying to achieve. So compared to the control group, the heart rate control was better and achieved in the Landiolol group. Regarding the secondary efficacy of mortality and other relevant clinical parameters, there was no difference between the two groups. So here you can see the heart rate difference, which was clearly achieved time after the treatment started. This is heart rate changes that you are seeing. This is over the first 24 hours. This is over the days. This is the diastolic pressure and the systolic pressure. No much difference. This is the norepinephrine equivalent dosage which was used. So you can see there is a little higher dosage being required in the Landiolol group, but this was not again statistically significant. So the key findings were that Landiolol effectively reduced and maintained heart rate, significantly higher proportion of the patients reached the primary endpoint, no significant impact on blood pressure or vasopressor requirement, heart rate control achieved quickly, that is within 24 hours, and remained significant up to 2 days. No survival benefit was noted. Regarding the interpretation of the results, adrenergic stress reduction by the Landiolol aligns with the study rationale. The primary response was consistent across the subgroups. Landiolol had higher heart rate response despite 36% of the controls receiving antiarrhythmic medications, and largest multicentric trial to date on beta blockers in sepsis. Regarding the limitations, no mandatory hemodynamic monitoring or echo was done, which could be problematic. Investigators may have increased the vasopressor dose instead of adjusting the Landiolol. Fixed heart rate approach may be seen as too aggressive for some patients. Baseline cardiac output was not measured, limiting individualized treatment. And inclusion of patients with pre-admission beta blocker might have influenced the responses. Subgroup analysis showed possible mortality risk increase in sinus tachycardia, but a trend for improved survival in AF patients. Regarding the safety profile, it has a similar safety profile with the standard group. Hypertension was 5%, bradycardia 2%, which was extremely rare. New onset arrhythmia were similar between the two groups. Antiarrhythmic medication use was definitely higher with the control group. Regarding future direction, identifying the patient phenotype that will benefit from heart rate control is required to be done. Hyperdynamic heart failure subgroup showed a numerical mortality reduction, so we need more trials on that. Potential benefit of patients with AF, again a future trial. More detailed hemodynamic monitoring could be better. Ongoing RCT is also looking at a similar role. So to conclude, Landiolol effectively reduces the heart rate in septic shock patients with persistent tachycardia. No evidence of survival benefit, ICU stay or vasopressor requirement. No major safety concerns though, but potential risk in sinus tachycardia. Routine heart rate reduction should not be a universal practice in septic shock patients. Subgroup findings with the AF warrant further research to refine our treatments. Thank you for your patience.